Lenara Tupa'i Fui is the Assistant CEO of Health Information Technology and Communications at the Ministry of Health, Government of Samoa, and together with her team has spearheaded Samoa's e-health project to improve healthcare across the country. She holds a Bachelor of Computer Science, a post-secondary diploma in Database and Information Management, and a master's degree in International Relations, majoring in ICT for Development. Lenara is also the elected president of the board for the Pacific Health Information Network, a regional network of professionals in digital health. Lenara is on a mission to harness the power of digital innovation to improve health outcomes for the Pacific community. Lenara will be giving us an introduction to the Pacific Health Information Network and an overview of the digital health experience in Samoa. So please join me in welcoming Lenara Tupa'i Fui.
Good morning, Salopo. So as Emily alluded to, there's two sessions to my presentation. Firstly, I'll be presenting on, because I'll be wearing two hats today. So the first session, I will be presenting as the president of the PHIN. And a little background on PHIN. So I'll be telling PHIN here. The Pacific Health Information Network was established in 2006. It is a regional partner network which aims to enhance digital health and health information initiatives. Excuse me, I'll just drag this up. In its member countries. It's okay when nothing goes right. Blend. Okay, continuing on. The PHIN structure is made up of a board consisting of a president and 4 board members. And it's made up of about 20 countries. So each country representative is responsible for promoting awareness of PHIN in their own countries. There are also 2 technical advisors, Mr. Laura Vivas and also Ms. Vicky Bennett, who's in the room today. And the secretariat to the PHIN board are the SBC and the WHO. We have 5 core values which guide our actions and decisions. In summary, these values are to ensure commitment in supporting our Pacific Island countries, to embrace our uniqueness, recognize our strengths and weaknesses, and be bold to make an independent decision on the solutions we need to adopt and contextualize to shape a better future in Pacific through digital health. We aim to promote a culture of country knowledge, sharing, and partnership. After all, no one knows the islands better than the islanders themselves. We must help each other advance together. Let's leave no one behind. Our mission and vision, with our goal to strengthen, build capacity, provide ongoing support to ensure initiatives we make in the digital health world are sustainable. And we will be launching our upgraded website soon, and also our Facebook page. So watch this space and also like our page so we can grow the number of PHIN members. That we come to the second part of my presentation, which is the digital health experience in the Pacific, specifically on the Samoa experience. For those who don't know, we have 4 main islands, 2 big islands and 2 small islands, with a total population, according to the census of 2021, of 205,000. We are home to the Tosua Trench. One time I saw that Somebody mentioned this was in Chile. It's not. This is in Samoa. And home to the best rugby team in the Pacific. So, all our health facilities, there's 12 health facilities altogether in our island. The main big one is in the main city, 2 referral hospitals, one in the main town and one in the other island. All our health facilities are interconnected via the government fiber. And this makes it easy for us to introduce our systems and implement systems out from the facility. We have a decentralized infrastructure in Samoa. So the Ministry of Health has its own ICT infrastructure. The government fiber is managed by the Ministry of ICT, but we manage our own servers, our email servers, internet, firewall connection, antivirus are all centralized, backup is all centralized, and IP phone system is all connected from the main. So we control everything from the main servers. If you use flash drives in the hospitals, in the facilities, we can view everything that's on your flash drive, especially if it's materials that should not be used on government infrastructure. We are also fully connected on the Digicel network and the Vodafone network, which makes it easy for us to implement systems on mobile systems, tablet or mobile phone. Since 2008, only 2 of our health facilities were interconnected, the main in Upolu and the main in Savai. With this, we were not able to have a fully digital patient health information system. Even though we were interconnected between the 2 islands with these systems, it was not implemented out in the health facilities. So the health facilities still collected their data manually or on Excel. So in 2019, we launched our e-health policy and strategy, 2017 and 2022. But before 2019, we have already implemented our WHO immunization system, which was not connected to our PHIN. And also in efforts to ensure we have a really good e-health system, we have been engaging the assistance of WHO technical assistance since 2013. And just when we were starting to settle on what pharmaceutical logistics management information system we were going to use, we had an outbreak of measles in 2019. Listening point from the previous slide, it's really important to have a digital health strategy. Not because it's only for a system, but a digital health strategy will guide everything that's necessary to have in place to ensure your health information system will work out well. Oh yeah, so measles happened. During the measles epidemic was the realization of the dire need to fast-track processes and discussions to have an information system in place. The top 3 challenges identified in the post-measles recovery plan was we needed to procure a system that's scalable. The WHO system that we were using could only be used from desktops in the health facilities. When we did mass vaccinations, you cannot take the system out in outreach program or out in the villages. We were finding it very difficult to get coverage because we did not have a unique identifier. On our PHIN system, we had 600 to 800,000 records against a population of just 190,000. We were vaccinating, the numbers were not going up. Also, the system was not, we had to manually enter data, so we were not getting real-time information. We did not have a GIS system, so we relied on the National Emergency Operations Center to give us these maps. So for our mass vaccinations, there was a national implementation, so we hired government vehicles, all the staff, government officials went out. With using these maps, we're able to know the roads. So this is map of roads. The challenge that we faced during measles was sometimes when you go one road, there'll be 4 cars there, and there'll be some roads with no cars. So at the end of the day, vaccination numbers was not even reaching the target that we wanted. That was the biggest challenge. But just because we had measles, it did not stop us. We had to still, we've come all the way from 2008 to try and have a system. So we continued on. And just as we had started implementing discussions with M-Supply, we also then, COVID happened. So we also then engaged the assistance of Beyond Essentials with an EHR system. This is where we came up with, this is where our journey with Tamanu started. And in 2020, we started discussions. 2021, the system went live for immunization. And with all our health facilities interconnected, Tamanu was implemented in all our health facilities. So now we have a system, an electronic health record system that can be implemented from all health facilities. Whichever patients that you enter from health facility on this side, you will view results on the other side of the country in less than 10 minutes. Were we going to use the PHIN data? Were we going to input 600 to 800,000 population data and then have the same issue of trying to find coverage, having patients with 6 records? It just so happens that in the same year, COVID was spreading like wildfire in the world. Our Samoa Bureau of Statistics carried out a national ID data collection process. This is also the census for 2020. So from this data, they got 212,000 population data. And because the country was on lockdown, nobody was going out, nobody was coming in. So it was the best data set that we thought we could use to start off our Tamanu. And we went with that. So we got governance approval, we got cabinet approval. Both CEOs of our organization signed an MOU for for data privacy. And then we sent this data off to Juliana and the team, and they inputted into Tamanu, and we got our data set for Tamanu. The system generates a unique random number, which is the Tamanu number. We now refer to this number as the national identifying number. One of the challenges that we faced with PHIN system, some people have 6 high chief titles or 7 high chief titles. Every time you visit a different facility, you might want to use whichever title you feel like you want to use. So your record was, it was really difficult to get one full record for one person. So with Tamanu, we have the Matai title field on its own. So we don't enter the Matai or the high chief title in the field of the first name, but we just move it out onto the traditional, I think they call it traditional name or high chief title. Also, one of the issues that we faced during the measles vaccination, some people did not have birth certificates, or some had passports, no birth certificates. Some had both birth certificates and passport, but date of birth was not the same on both of those documents. Lesson learned from there to be used to, so we now have on Tamanu the birth certificate number, passport number, and also the driver's license. Sorry, the photo is different. It's the driver's license. So you now have 3 official documents. You can use whichever one when you come in. Those information we will enter in. So if you come back with a different birth certificate and we already have your birth certificate number, it makes it easy for us to query whether it's the same person or not. And best of all, the system is available on mobile. So you can use it on tablet, the vaccination teams can take it out for vaccination programs. And after the implementation of Tamanu, we have trained more than 200 government officials and also more than 400 health staff. So it might not be clear, but the guy who is using a tablet and the staff is using a tablet as well. So each person is now identified on Tamanu. And this is the number, and this is the system, and this is what we used for our COVID-19 vaccination. So on our COVID-19 vaccination card, the number that identifies you is the number of the Tamanu ID. And then when we enter in your information, we go back, relax, and watch the mappings. So when we enter your village, it will appear on Tamanu. So we had our first strategy for vaccination was to focus on the main town, because that's where the population is most of the time. But when we were vaccinating the town, we noticed that there were other villages with people already getting vaccinated. We were a little bit cautious in vaccinating because we didn't want number of anti-vaxxers to grow fast, because we were trying to vaccinate, and also there was not enough COVID-19 vaccination, so we didn't want to waste virus. So we changed, using this map, we changed strategy, and then we tried to start implementing in rural Polu. Around this time, borders were open between the two islands was closed in the afternoon, closed in the evenings. So there was minimal traveling back and forth. But when we were vaccinating rural Polu, we noticed that the other island now appears to have some people already vaccinating. So we were having people coming from the other island willing to get vaccinated to Polu to get vaccinated. This means that we shouldn't be keeping it to ourselves. We need to open up vaccinations and have it available for the whole country. And with that, made it really easy for us to monitor which village was behind in vaccination and which village was doing good. So then we can allocate our resources. We don't need to send cards every now to villages that are doing really good. We can just send them to areas that are red. Also, when the areas that were red, usually we would think that those people did not get vaccinated, so they had to go to their houses. But when we turn up, some of them were not eligible. So they're either pregnant or some of them have already left, because even though borders were closed, we were still open to repatriation flights for seasonal workers. So some of them have left for seasonal work, and there was no need to follow up with them. So the team also, the developers also developed a field for not given. So then we can mark them as not vaccinated for a reason, so they don't appear red on the maps. There were also district level mappings. And district level mappings made it really easy to identify which districts was not doing so well. We then use these maps, crop them, and then have our awareness and promotion programs using these maps. So this was a more interactive way of feeding back to the public how they are doing. With these maps, we export the district level percentage of vaccination for your village. And these are the reports that we pass to higher level, to cabinets, to parliamentarians, because then they'll be the ones to talk to their districts if they are not doing so good. And the one thing we love about Pacific Islanders, we're very competitive, so parliamentarians are very competitive. And you'll notice that once you start giving up the math, it went green in a short period of time. We're also able to have household level reportings. So when all the vaccinations and all the districts were turning green, it was really difficult to find. There were still some villages with a hint of orange. It was really difficult to identify who. So we know which village it is, but whose house it is, because now the villagers want to know who of their village. And also we got really good support from the village reps, because you get fined if you don't get vaccinated for some villages. And it was a really good push to getting our vaccinations done. So the household level mapping, it picks up your household, and then it doesn't have any identifier to it. All the data remains confidential. So it's only a dot of your house, and this high level mapping is only available to house staff specifically who will be specifically going to the households. And then there'll also be a member of the Ministry of Women that goes along with them, and then discuss with the family why they're not vaccinated and all those. And then untick them or tick them if they are not eligible. Maybe they are only 1 year old, but their date of birth was wrong on the system. Or also they have already relocated, but not already modified on the system. So with the village mapping, we are now able to see the households. We know exactly which household, but sometimes we may not fully understand where the road is. So those maps we send to the National Emergency Operations Center, and they give us these maps, which now kind of makes sense. Like it's easier to collate the one map against the other, makes it easy to find the road and find the house. Sector collaboration is really important. With the implementation of Tamanu, we're very, COVID actually helped sped up our adoption of the EHR system. And with the implementation of Tamanu from the start, we had involved the Ministry of Women because of their involvement with discussing matters with the village reps, and also the Samoa Bureau of Statistics, because that's where validated and verified data comes from. This was the same strategy that we used when we had a COVID community case in March. So the first strategy was test everyone in the main center. But as we were testing, we noticed that it was spreading, positive cases were spreading. A family member from Savai came to do some shopping in town and got infected, and it was picked up by the health facilities. So we were able to give assistance early to the health facility in that location. We have not used the laboratory function of Tamanu before, but because of the COVID community transmission, we just called Michael around 10 p.m. in the evening and woke poor Megan that was sleeping. And in 1 hour, 2 hours, the system was up and running, and we were able to enter all information in, which made it really easy for us to pick up the spread of COVID-19 vaccination from the health facilities. The one thing about Tupa'i is that it's very versatile. Not only does it pull information from Tamanu, it can also pull information from whichever digital system there is that we need to pull information from. It was very difficult. Now with community transmission, we cannot do any more trainings for entering information onto the Tamanu system. The easiest way and a system that's accessible to everyone was Google Form. So what we did is we created a Google Form with assistance of Michael, and then we sent this out to everyone, put it up on our Facebook page, our website. Everyone can scan, because now we were giving out the rat test, so you can test yourself from home. And already with Google Form, you can access on your own personal phone. All the information started sinking in. And then we can see the positive cases growing. Stores were still open. It was still there. It was a sad scene, but it was we were already in lockdown and the world was already in turmoil with COVID. these are the powers of Tupa'i, of systems. But I feel like sometimes when we're given systems, we should not limit ourselves to what we're just given. We should empower ourselves, open our minds. If we understand the process, we'll understand what we want. Then the developers are better able to cater to what we want to appear on the system. We also implement M-Supply. I presented on this yesterday, but somebody said he missed the presentation, so he said he wanted to see again. But this is one feature of M-Supply that we really love. These are the reporting for health facilities. One of the biggest challenge with implementing systems is people do not want to do data entry. But with these reportings allow us to monitor. So we can go down to, this is a national level reporting, where it compares each health facility against each other. So you will know whether you came first, you came second, how did you do, your average. And we can also go down to facility level. So facility level will tell, these are what we grade you against. This is how you get your number. So this is like biology, chemistry, English, and your best three. If you don't do so good, then you get a low average. But if you do very well in all the numbers, then you get a good average. The one feature that we really rely on is the days since last transaction. When we implement systems, usually people will say there's no internet, they need more data, there's no credit on tablets. But when we check further, this is days without a transaction across days since last week. So this will tell you how many days the system went down. If it says 0, then that means the internet was connected, your computer was connected, you just did not enter your data. But if it's 1, 2, for us, 2 days is already too late. We have to fix within 24 hours. So if it says 1, then maybe they're telling the truth. So that's when we action. So we call them, check all the wires, do a troubleshooting from internal, and we solve the issue fast. One other feature of M-Supply that we've implemented we really love, and I think the immunization team really love, is the cold chain system. So with the cold chain system, there's a Bluetooth sensor inside the vaccine fridge, sorry. And then there's a tablet outside. So the temperature information is fed back from the sensor to the tablet. And then it puts out all the information. And that's where then you'll know whether there are any breaches, any vaccines that need to be checked. Also, it gives you battery number. So you would know you need to charge the battery, or the power supply to the battery is not working, to the tablet is not working. That's where my team will work on. Fix the issue, change the battery, or call Carol for support. I think ever since we implemented this system, the immunization team have been able to sleep well during the weekends and after hours. And I've also been able to sleep well after hours, because every time they want to check, or when there's an issue, the power is down, the tablet is not syncing, they will call our team for support. But with the implementation of the system, it's also implemented on Telegram. So you get a message on Telegram when there's an alert, the power is off, there's no data. It sends an alert to your Telegram. So all of us, that will be myself, the maintenance team for power supply, and the immunization team for checking the vaccine stuff. No matter how sophisticated a system is, if the users don't find it helpful, if they don't enjoy themselves using the system, then it will be really hard for everyone, for them and for us to push them. Because when we implement systems, the reason why we implemented them in the first place was because it's going to help us. So if it's taking us a lot of time to push people to use, then something is not right somewhere. So what we encourage is to make sure the system meets what the users want. We have to bridge technical skills with imaginative solutions. and present it in a language that lay people understand and make it easier for their processes. Then we don't need to go train them at all. Sometimes they train themselves. During our implementations, we relied a lot on our systems really still need some traditional touch to it. So we use our pastors to get the message out. We use our village reps to get the message out. And it makes it easy. When people start coming, then we start using the system. Because if people do not come, then the system is also a waste of time. So we should empower our senior staff to be trainers. I'm sure a lot of us do not like training, a lot of people. So one of the good things that we do is we always try and train trainers and promote the use of the system. And we've been really lucky that we have really good staff that can train themselves. I think the nurses, we finish training, but they just love training themselves. So every now and then they send us photos of themselves training. Our immunization team, our coordinator is also here. She does training for Tupa'i and the vaccination module. Our surveillance team, also our IT team. I still had to put a photo of Tim there, just to acknowledge all his work. And also the pharmacy team. With the M-Supply used for warehouse and the pharmaceutical team, they do the training, most of the trainings themselves. We only come in to fix tablet issues or network connection issues, but the warehouse team does the training all on their own. And the same goes for the immunization module. That's to empower our non-ICT staff to lead implementations. I think if I were to go and do trainings and promote the use of the system every now and then, everyone will get tired of me. And I think pushing Tamanu will not even work up to now. One of the other issues that we really need to avoid is pilotitis. Pilotitis is a term commonly used in digital health to describe the tendency to launch numerous small-scale pilot projects without committing to or scaling projects to full-scale implementations. This sometimes happens when there are different programs and they have different fundings for those programs. Pilotitis sometimes encourages territorialism. Like you try to, this is your part, if it's funding for AIDS, this is yours. So we only buy AIDS related hardware or things with the funding. Whereas if we share the resources, then not only do you help your program, you also help the other program, and also help the program overall. Taking a holistic approach. We need to strengthen our internal and external collaborations. We have a national ID project that's coming up, and we also have a street addressing system. We really need to connect to these national systems. One thing is because our people are very mobile, they change villages within months. They'll be in 3 different villages at one time. It's very difficult. So if we don't change your village on the system, it will appear like you're in town, but really you've already shifted to a different location. So if there's an outbreak, it's very hard to identify who's who where in the country. Also with the National ID project, this will really eliminate having duplicate records. We are already trying so hard at the moment with Tamanu, but we still have people that have two names coming with different date of births. Sometimes it's genuine, but sometimes there are people that are doing it deliberately for some reason. So the only way to eliminate that is to connect to the National ID project. So that one number can filter the necessary information to our system and then modify our system and back and forth. One of the developments that's worked and we are very proud of is the birth registration process. For years, we've been trying to digitally record births in a timely manner from the health facilities. With the Tamanu now implemented from all health facilities, birth registration for the first time is done from the health facilities themselves. It was hard at first when we started, in the beginning of the year, only 3 health facilities sent in the information. So I had to work with them. We had to also give them feedback, say who's red and who's green and who's orange. And then by May of this year, 90% of our health facilities have already started sinking in. And the other best thing about this is data is entered by the midwife. When we just started implementing and trying to promote system, midwives did not want to enter data. They kept saying that's not their role, same as immunization. When we started the immunization system, vaccinators said it's not their role to enter information. But now they are entering it themselves. Even for birth registration, the midwives are entering this information. Sometimes the data officer helps. But it is a step, progress is progress, and we will build on that. The other good thing about Tupa'i is it gives out all this information. Usually we have outreach staff, the health information division goes out every month to collect information. Now all we do is just monitor on Tamanu, and then monitor on Tupa'i, call the team if the numbers don't match, and then try and reconcile from there. Then we can go every quarter and follow up whether the numbers are correct or not. Saves resources, saves time. With the paperless process, we had implemented this in our ENT clinic, and paperless process is removing the use of the paper record fully. We implemented this with our pilot, with our ear, nose, and throat clinic, where the medical record will check on Samanu, check your record, enter details, appointment on the system, the triage nurses on the other side, checks the vitals when the patient comes in, the doctor checks you when you come in, and information is already entered on the system. No need for paper records to enter data. And the good thing about this, all the information is then synced on Tupa'i, and we are able to get in real time how many patients will walk in, how many were scheduled patients. Getting the data by day makes it easy for reporting, and also makes it easy for the health information division. We've also just launched, we also just went go live with 2 facilities, now going fully paperless. And we're aiming to complete the other facilities when this process is only in 2 steps, but it's not an easy process. It's gonna take a while. And sometimes I think when I'm presenting and using just 2 slides, everyone thinks it's easy and you might give up with trying to use the system that you're currently using. But this is why it's really important to have your digital health strategy in place to guide the implementation, and then see where needs more funding and needs more focus. So this is an example of one of our facilities out in the further end of Upolu. All the information is entered in, and then you get all the pretty looking map. You'll know which village in that district the most patients are from, how many patients per day. Also, one of the biggest challenges we've had through the years was trying to calculate the waiting time. The system is now able to calculate and give you a waiting time for the process. And also you're able to see a summary of what were the clinics that were most visited. And it makes it easier for the clinic or for the facility to plan out their resources better. Also, I would like to say that all the pretty maps and all these, if you do not enter the data, nothing comes out. So one of the biggest lessons that we need to encourage is to enter the data. And in order to enter the data, you also have to make sure the staff have the resources to enter the data. Those are all the good reportings. You can get the top 10 diagnoses for the facility. And these are, when we say systems for easier decision-making, now this is systems for easier decision-making. We were so used to using Excel, where you collect the data and then you analyze it again. and a lot of the staff at the health, at Ministry of Health are not data analysts. So there's always an error with analyzing information, but with these, you can get information straight away and back to your users. The future looks exciting. So we will be implementing our Senite system soon. And also we already have our X-ray system in place, not yet connected. There will be discussions and we're hoping that it could be connected to Manu, so we can have one system with everything else interconnected. And also just wanted to highlight here, one of the biggest issues in the past was every funder wanting to fund a certain part of the system, so they don't want to put in their funding into the system that's working for us. But one of the things we really pushed and has worked for us since implementing the system is the funders seeing the results and putting in funding where it will be most beneficial to the ministry, not to the funder. And the most important, last slide, invest in your team. Sometimes we're very hard on ourselves. We don't socialize. But one of the biggest things, and we thank BES, this is the first time we've ever had an organization pay for a social activity for us. One of the things that we really need to push is to build capacity of our staff, seek avenues where our staff will be able to learn more, even if it's not, even if it's trips like these, it will really build their confidence and motivate them to work better, even if the salaries do not go up. But maybe trips will cost more than the salaries. A trip was also best. And that's it from me. Thank you very much.